Hello everyone. For those who are just now attending for the first time, my name is Nipat Paninanto. I am a resident doctor in my third year of training in orthopedics. For the second session, the topic is complex proximal femoral fractures. During this session, Dr. Suvicha Sripadungkul and Dr. Pongthorn Siritianchai will be our co-moderators. Ladies and gentlemen, please welcome them to the stage. Enjoy the session.
Good morning, Chairman, Co-Chairman, and all participants. This is the second section of this room for this morning, the complex proximal femoral fracture. My name is Suvicha Sripadungkul and my colleague.
Pongthorn Siritianchai.
Okay, so to be straightforward for the time, we would like to start the first section of the first topic of this section.
Okay. May I invite Dr.Gawin Peanmee for the topic femoral neck fracture in young adult, upcoming trend in fixation, please.
Good morning, everyone. My topic is femoral neck fractures in young adult, upcoming trend in fixation. My name is Gawin from Somdet Panang Chao Sirikit Hospital. This is the outline of these topics. The femoral neck fracture in young adults mean the age of patient is less than 50 years and is accounting for 3 to 10% of all hip fractures. And it happened in high energy trauma and in hip axial load while hip in abduction and abduction position. This type of fracture has high incidence of complication, AVN, non-union, and fixation failure. The major blood supply to femoral head is come from medial femoral circumflex arteries that give a branch to lateral ascending cervical arteries lie on femoral necks. So, in a highly initial displacement like this, it may injury to that blood supply. The AVN and non-union has many variables. In highly initial displacement, posterior comminution, highly power angle is injury factors. But the only one factor that surgeon can control is quality of reduction. The fracture pattern of this fracture group is basic cervical fractures and vertically orientation fracture line. The classification is Guardian classification and Powell classification. That's widely used in this fracture type. In the type 1 is less than 30 degrees. It has a horizontal orientation of the fracture line and it has compression while you fixation. But in the type 3 that more than 50 degrees, it has high shear force and varus moment. So it has highly rate of fixation failure, AVN and non-union. In management concept in this fracture group, its goal is preserve femoral head and avoid complication. In this fracture group, is not good candidate for arthroplasty. And it has so many controversial issues. In timing, we have evident no association between timing and incidence of AVN, and no benefit to do emergency fixation, but you should do in an urgent basis. Decision making. You can do fixation in a hemilithotomy or supine on fracture table, or in the issue closed versus open reduction. It has a study to compare closed and open reduction. It shows no significant on the ON in with two groups. You can choose closed or open, but you should know how to get good reduction or acceptable reduction. The intra-op access reduction, you should follow lower pattern or lazy S in the AP and lateral view, like this. or you can choose Garden Alignment Index. Surgical approach. The anterior Smith-Peterson approach is an approach between sartorius and muscle and tensor fascia lata. It's a direction approach to fracture, but you need secondary approach to fixation, and it's based for visualized cervical fracture or subcapital fracture. Watson-Jones lateral approach is an approach between tensor fascia lata and gluteus medius, and it's best visualized for basic cervical fracture. Hunter approach is a muscle sparing approach. It's the same approach for the ATHR, and it's based cervical. It's based for cervical or subcapital fracture. This is an example of reaction tool you can use for fixation. Fixation tactics you can use like the joystick, like this, or you can get the direct compression to the fracture site with Ibercam, or you can manipulate the fracture site via Jung Brute like this. Multiple cannulate screw is widely used in the femoral neck fractures. The pro is minimal invasive, short operative time, less blood loss, and good for Powell 1 and Powell 2. In the Garden 1 and 2, you can fix it like in situ fixation, but it's not strong for Powell 3, basic cervical or comminution fracture. In Powell 3, you can use medial plate augmentation for increased fracture construct, or you can use Powell screw or off screw. This screw is a screw that perpendicular to the fracture site to increase fracture construct. A dynamic hip screw. Dynamic hip screw is a fixed angle, and it's good for basic cervical fracture or highly Powell 3. Femoral neck fracture is a stable implant, and it's a new implant for fixation femoral neck. It allows compression but no protrusion of implant, and it's good for all fracture type like the Powell 1, 2, or 3. This is a retrospective study comparison FNS versus dynamic hip system blade. In the FNS group, it shows less femoral neck shortening, and it gives highly Harris hip score. If it has a shortening of the femoral neck, it has a less length and an offset, so it's decreased abduction arm moment and decreased limb length discrepancy. This is a biomechanical comparison of femoral neck system versus interternal or 3 cannulated screw for unstable Powell 3 femoral neck fracture. The load deformation curve is show FNS group has a can provide increased stability than cannulated screw. This is case 26-year motorcycle accident. Ipsy lateral sharp and Powell 3 was treated with the first doctor with long PFNA with CIF technique. At 3 months, he found his loss reduction at the femoral neck, but you can see callus on the lateral side at the femur. And he consulted me. I decided to do re-op with the remove long PFNA and do OIF with FNS like this. And this is a second case, 18-year motorcycle accident, and has a comminution and Powell 3 femoral neck fracture at the right side. Okay, I decided to do open reduction and internal fixation like this with the FNS. Okay, take home message. Femoral neck fracture in young adult is occur in 3 to 10% of the femoral neck fracture and is high energy trauma. And this type of fracture is high complication rate, AVN, non-union, or fixation failure. Quality of reduction is the only factor that we can control for good reduction and outcome. This type of fracture need primary bone healing. Is not can last in this fracture group, and it need stable fixation. Anatomical reaction and stable fixation is the key. Thank you.
Thank you, Dr. Gawin, for the wonderful lecture, wonderful topic.